In Chapter 20, we will be going over the spine. The spine has three main segments, with the sacrum also added on down at the bottom. So our main segments of the spine are the cervical spine, the thoracic spine, and the lumbar spine. So cervical spine is in the neck, and there are 7 vertebrae here. These are built for mobility. So the cervical vertebrae are structured so that they move better and more than the other vertebrae. The thoracic vertebrae are in the mid-back, and we have 12 of these guys. And they also provide some mobility, but less so than the cervical. The lumbar vertebrae are the low back, and there are 5 vertebrae here, and they're very strong. These are built for stability and strength. So as we go down, the vertebrae get bigger because they're bearing more weight. The other thing you'll notice about the way the spine is, so we have different curves of the spine. So the cervical vertebrae curve this way, the thoracic vertebrae curve this way, and then the lumbar vertebrae curve that way. That's a normal position of the spine. It helps with shock absorption. So the spine is not meant to be straight. We're meant to have some curves there. They're just not meant to be excessive. Then we have our large flat fused vertebrae called the sacrum at the bottom of the spine. And we do have nerves that exit the spinal cord through the sacrum, which is why it's kind of considered a part of the spine. But those are special fused vertebrae, and we don't give them individual numbers like we do with the rest of the spine. As far as anatomy of the independent vertebrae, we have, again, a lot of vertebrae in the spine, but we have 2 special vertebrae in the cervical spine, or in the neck. So the C1 is called the atlas. So the atlas is a kind of just a little loop of a vertebrae. It's not shaped like all the others, and its main job is holding the head. So the head, the skull, sits on these little joints here on the atlas. It's called the atlas because in mythology, Atlas was a god who held the world on his back. So Atlas is holding the world, or the head, on its back. The axis is C2. So the axis looks a little bit more like a normal vertebrae. The axis is down here, but it's got this little thumb-like projection that projects up through the atlas and allows for rotation of the atlas on the axis, which also allows for rotation of the head. As far as the rest of our quote-unquote more normal vertebrae, each vertebrae is going to have a body, or the big part. The bodies of the vertebrae actually don't touch because we have disc material that's sitting in here. So that's actually not where our true joints, where the vertebrae touch is. We have a central foramen. So this is the hole the spinal cord goes down right here. We have a spinous process. So that's if you reach back and touch the back of your neck and you bend forward and you feel all the little bumps on the back of your neck, that's the spinous process. It's the part that's most easily palpated, but it serves as a site for muscle attachment. We also have our transverse processes. If you're bony enough, you may be able to feel those also just a little bit off to the side of that spinous process, but those are also muscle and rib they provide muscle and rib attachments there. The other thing that we'll have on those transverse processes is the facet. So the facet is actually the joints of the spine where they touch. So in this picture it's not marked, but this would be the facet. So in another picture we'll be able to see better how those vertebrae attach to each other, but basically we're going to have a little projection that comes down and attaches from the spine, or the spinal segment above, or the vertebrae above, to this vertebrae at that facet. We also have what's called a rib facet, and that's where the rib meets the vertebrae right here. We have one on either side. So the ribs attach to the thoracic spine only, usually. Sometimes people have an extra one up on the lowest cervical vertebrae, but they're supposed to be just on the thoracic vertebrae. As far as anatomy or soft tissue goes, our ligaments here, our biggest ligament is going to be the ligamentum flavum, and this runs the length of the spine. It's a big, tough ligament that helps to provide stability to the spine. Another soft tissue that's important to talk about is the disc, and we'll talk more about disc injuries later. But with the disc, this is kind of like a cross-section of the disc, like it was sliced in half, like a bagel. And this outer portion is called the annulus fibrosus. So that's a relatively fibrous, dense, hard covering. And then the inside here, or the jelly filling, is the nucleus pulposus. So I tend to either think of this as a jelly donut or like an orange. So the donut part is the annulus fibrosus, and the jelly part is the nucleus pulposus. If we're looking at it from an orange perspective, the annulus fibrosus would be the hard peel, and the nucleus pulposus would be the smushy fruit on the inside. When we have injuries to the disc, what will happen is that hard outer covering will become damaged, and the jelly filling will push out into a space it's not supposed to be in, and it causes pain. We'll talk more about that later. As far as the muscles of the spine, we have the erector spinae, which are a group of extensors. They also help to stabilize the spine. So the erector spinae muscles are the intercostalis, longissimus, and spinalis. But basically, it's just a big old group of muscles that extends the spine, that runs down the spine. So it's similar to calling, the quadricep muscles the quadriceps. The erector spinae is a muscle group. The quadratus lumborum is an independent muscle by itself, so it goes from the spine to the posterior iliac crest, and it can hike the hip independently. So if we just contracted one of them, it would hike this hip up. If we contract both sides, then it will extend the spine. Then we also have our multifidus muscles. They're super duper important for stability for the spine. They run between the spinal segments or the individual vertebrae, and they kind of look almost like shoelaces lacing up the spine here as they do that. The multifidus muscles in particular, based off of research, have been shown to be some of the major stabilizers of the spine. They're also some of the smallest muscles in the spine, and they're some of the first muscles to shut down when we have back pain or back injury. So at least at the physical therapy clinic I work at, we spend an awful lot of time trying to get these multifidus muscles stronger. We do have multifidus muscles on each side of the vertebrae, so we have on the right side and on the left side. Independently, they'll rotate, so if we are contracting the right side, we'll rotate that direction, and then together they can help extend, so if we were contracting both sides at the same time. But a big part of their job is the stability of the spine. As far as nerve anatomy, this is very important when it comes to the spine. We have 8 cervical nerves, and so not 7, because we actually have an extra one that comes out above C1. So we have the extra one at the top, and then we have another 7 to correspond with the rest of the vertebrae. Then we have, and those nerves supply the upper extremities. So those go to the head, neck, and arms. And the thoracic nerves, there are 12 of those. Those correspond with the thoracic vertebrae. So coming through there. And those nerves supply the thorax and abdomen. So they'll supply the sensation and movement for the muscles in those areas. Then we have the lumbar nerves. We have 5 of those. So coming through here, and again corresponding to their respective vertebrae. And the lumbar vertebrae supply the lower extremity, so the hips and legs primarily, and then the sacral nerves will supply the lower extremity and also the pelvis. So we also have another term that's important to be aware of. It's called the plexus. So we have a couple of different plexuses, or plexi, I guess. We have our sacral plexus, which is down here, and then we have our brachial plexus, which is up in the arm area, kind of in the neck region, and we also have a cervical plexus a little higher. But basically what happens in the plexus is you can kind of think of it as a big intersection of nerves. So we have our nerves that come directly out of the spine. So that would be like cervical nerve 2, say for instance, or C2. And that C2 is going to come out and it's going to intersect with some of the fibers from C1, say for instance. And then they're going to come down and then they're going to split off again. So these nerves would be more considered to be more peripheral nerves versus spinal nerves because they're taking little pieces or some of the fibers of those spinal nerves and making a new nerve out of them because they're on a different highway path. As far as prevention of cervical injuries, really important is having appropriate muscle strengthening. So we want muscles to resist hyperflexion, hyperextension, and rotational forces. So this is the same for athletes and for individuals who are just having neck pain. So we want to make sure people are strong enough in all of those motions to be able to do what they need to do for their daily activities. If we are talking about a contact athlete, we want somebody to brace their head by contracting their neck muscles prior to impact. We also want somebody who's tackling another person to be looking up, not down, because it's much more protective for the neck. It allows safe motion as opposed to if they were looking down and they got a blow to the top of the head, then that would be pretty dangerous. A range of motion here is important, so we want somebody to have full range of motion to prevent injury, both chronic injuries and acute injuries. If somebody can't look over their shoulder all the way and they're driving, they could get into a car accident. If a rugby player can't look over their shoulder all the way, they might not be able to see the person who's about to just completely light them up with a huge tackle. So full range of motion is important for a lot of reasons, but especially for chronic injuries, it's going to reduce chronic pain. We want people to use correct technique. So with tackling, we want them to avoid using their head as a weapon. And again, keeping their eyes up. And if somebody's diving into water, we should not be diving into shallow water. That's why people aren't supposed to dive in less than 6 feet of water. Interestingly, people who are trained divers who do injure their necks, it's actually because they're a trained diver that they injure their neck, because what trained divers, like somebody who's done the high dive, say for instance, what they're trained to do is they enter the water and they immediately flip over to come back to the surface. And if they're diving into shallow water, when they do that, they hit the bottom of the pool or the lake or whatever they're diving into with their head in a flexed position, which is a more dangerous position, and they're more likely to fracture their neck. As far as prevention of injuries for the lumbar spine, we want to try to have people avoid postures and positions that can cause injury. Sounds really easy, but it's a lot harder than it sounds to actually get people to do this. So we want people to avoid slouching. We'd like them to sit up tall, keeping a nice natural curve in their lower back. We want them to avoid leaning to one side, and we'll encourage people to keep both feet on the ground when seated instead of crossing their legs. So those are some examples. Again, like keeping the natural curve of the spine is pretty important. Also making sure that we're not lifting with our back if we have to lift something. So sitting down more, bending the knees more to try to lift an object, bring that object close to the body with the chest up, and then stand up. That would be a good posture that could avoid injury. Strength and flexibility is important, so we want to have that person be conditioned for their activity, emphasizing trunk and hip flexibility. Also, the spine extensors and abdominal muscle strength should be stressed to maintain proper alignment. As far as abdominal muscle strength, specifically the transverse abdominis is super important. So that would be that muscle that holds your guts in that we activate by drawing the belly button in. That's the only abdominal muscle that actually wraps around to attach to the spine. So that one is super important, and we'll talk more about that later. And strength and flexibility must be based on an individual's needs. If I'm treating a patient, an 80-year-old lady for chronic low back pain in the clinic, that's pretty different than if I'm treating a 40-year-old delivery person with a disc issue. They're going to need to be a lot stronger than the little old lady with chronic back pain. Again, touching on using correct lifting techniques for prevention of injury, we want to always make sure that people are taught to keep their shoulders above their hips and use hip hinging in a good squat or lunge position when they're trying to lift something. Instead of bending forward with locked knees, with allowing the shoulders to become lower than the hips, say for instance. So we want somebody to keep their chest up, hip hinge and squat or lunge down depending on their knee condition or what position they can do most comfortably. Then we'll ask them to bring whatever object they're picking up close to their body prior to coming upright or twisting. People most often hurt their back doing the bad BLT is what we call it at work, so bending, lifting, and twisting. So we want to try to make those motions slow and purposeful and safe. Weightlifters can minimize injury of the lumbar spine by using proper form, breathing techniques, and spotters. So as far as breathing techniques and lifting, we want to always exhale with exertion. So whatever the harder part of the exercise is, we should be exhaling during that time and inhaling during the easier part of the exercise. Weight belts can be used for added stabilization for heavy sets, but we don't want to have people walking around the gym the entire time they're working out with a weight belt on. It's not necessary, and it actually discourages the body from using the muscles as stabilizers, which is really important. As far as core stabilization, this can increase lumbopelvic hip stability. So we'll talk more about the core muscles and how to use them. And also increase stability with the core, so like the transverse abdominis and the gluteus medius especially, helps the athlete maintain the spine and pelvis in a more comfortable mechanical position, and that can prevent microtrauma over time as well. In addition to, if I have somebody who has to lift heavy things for work, or have a couple of lift techs that work in intensive care or the ER right now that are at the spine clinic, and I just tell them, if you can't bend your knees and get your hip hinging down, at least do your best to contract your glutes and your transverse abdominis prior to trying to move somebody, because that puts you in a much more stable position than just moving them however you're going to do it. As far as history for spine injuries, please remember that the information provided here is for informational purposes only and to help triage with an injury. First, we're going to want to figure out the mechanism of injury. So how did they get hurt? This is primarily to rule out spinal cord injury first, at least. So especially if somebody's having neck pain, did you hit someone or did someone hit you? Did you have a loss of consciousness? Remember, if somebody has a loss of consciousness, we're always going to assume that they could have a high likelihood of having a spinal cord injury. Do you have pain in your neck, numbness, tingling, or burning? This is more concerning if it's down both sides than one side. So if it's right and left, that would be more concerning. Can you move your toes and fingers? If they have any problems with any of these things, then we want to make sure we're using extreme caution when the person is moved, and we probably won't want to move them in the first place until an ambulance gets there. If they don't seem to have a spinal cord injury, we'll ask them, where is the pain? What kind of pain is it? What were you doing when the pain started? Did the pain start right away? And how long have you had it? Interestingly, after somebody's been in a car accident or something like that, it can actually take a while before their back or neck starts to hurt. Sometimes it starts immediately, and sometimes it doesn't start for 2 days to a week. I've had patients who've taken almost up to a week to have pain start. And so it took them a long time to put together that's what caused it. What positions and movements increase and decrease pain? So when people have chronic low back pain, it's common, especially with older patients, that I've noticed that it's very common for them to have morning pain. But when a patient has more like a spondy, which we'll talk about later, or a small fracture in their back, they tend to have more pain in the afternoon. When people have because of being on their feet all the time, when people have pain in the morning, it's oftentimes from laying in bed all night and then getting up and moving. when people have a disc issue, they tend to like to have their back extended versus forward flexed. So a lot of those positions that they prefer that's actually really important information because it helps to direct us towards what injury they could possibly have. Past history of back pain and what's their sleeping position pattern, what positions are they holding often throughout the day, so prolonged positions like do they sit a lot, are they standing a lot, are they walking a lot, do they have to have one patient right now who's a forest ranger, so he's having to go out and use a giant chainsaw to cut down tree branches, and he's in his late 60s, early 70s, so it's pretty hard on his body. For spine, doing observation is really important. At the clinic I work at, we actually have a really neat app on our tablets that does postural evaluation, but there's a lot of things you can see with the naked eye as well. So postural alignments and asymmetries should be observed from all views. So you want to look at people from the front and from the side at least, but also from the back is a good idea. We can assess height differences between anatomical landmarks. So a good example of that would be looking at the iliac crest. I would looking at the pelvis to see if it's symmetrical. So sometimes you'll have one side that's shifted up or hiked up because, like, say for instance, the quadratus lumborum is spasmed on that side. It's actually probably more common to see one of those ilia rotated forward. So it'll rotate forward like that, as opposed to hiking up. And we find that by looking for their anterior superior iliac spines. We usually do that in supine position. And another thing we can look for is, again, just general posture, like how do they carry themselves. So this gentleman here, in this first picture, he's got a pretty kyphotic posture. His head is pretty forward here. So if we were to find his ear, my guess would be up here. And his shoulders are very forward rounded, so you can see they're facing that way. His sternum is also kind of facing forward, or a little bit even down. And he's got a very big, what we call the rhodotic curve here in his low back. Sometimes when people have that much lordosis, they can have discomfort from that. Again, if they have a disc issue, they actually might be more comfortable in that position. But it looks like he went through some sort of probably weight loss program as well, or he learned how to use his TA because he looks like he's got a flatter stomach here over time. That ear has been pulled back a little bit, it looks like. I don't know if you guys can tell that as much, but he's much more upright with his neck. He's not as head forward. His kyphosis is slightly reduced, but the biggest difference I see here is that lordotic curve. It's not jackknifing like it was on this side. It's a much gentler curve, probably because he's learned how to use his transverse abdominis muscles, and he's just doesn't have as forward of a pelvis as he previously did. He's more centered. So that's one type of posture we'll see sometimes. Another common type of posture we see, especially in the PT clinic, is when people bring their head forward, their mid-back will go back to kind of keep their center of gravity, and then the hips will come forward. So this is the first picture is what it looks like with a slightly younger patient. My guess would be she'd be in her 30s or 40s. And then over time, though, that position doesn't just become functional, it will become structural. And so these older ladies come in and they're stuck in this position where their head is so far forward, they have this really big kyphotic curve that has become more structural, and so it's hard to undo that, basically. And that can cause a lot of mid-back pain or neck pain or even low back pain because it's pulling that person forward. The other thing it can cause is falls because you're just not as balanced in that position. I tend to tell my patients, don't look down at the ground when you're walking, at least not directly in front of you. If you want to look out, that's okay, but our bodies tend to follow our eyes. So when we start to have that much of a forward head, and we start to look down, it's going to increase our risk for falls. So that would be one thing if we're trying to decrease fall risk, is to have people begin to become more upright, sit with better posture more throughout the day, and stand with better posture more. Next, we'll talk about palpation. This should be performed while the athlete is or the client is prone on their stomach. A position of comfort when people are on their stomach when they're having back or neck pain would be that the head and neck would be slightly flexed. So possibly putting a pillow under the hips would help with that. And then that also, and sometimes we'll even put a pillow under the feet depending on if that person's comfortable. Sometimes people need 2 pillows under the hip to be truly comfortable. As far as the first, we're going to palpate the spinous processes. So again, the part that really sticks out in the back, it's easy to feel. That's our starting point. And then the transverse processes are just a little bit to the side. And we're going to do that for each vertebrae. And we're also going to want to palpate the sacrum and the coccyx. Now, the coccyx is the tailbone, so we have to be a little careful when we start to try to palpate the sacrum and the coccyx. We don't want to use our fingers in a way that makes the person uncomfortable. So usually if I'm going to palpate the sacrum, I'm going to make sure that my fingers are facing up, and I'm going to use the heel of my hand. Basically, we want to keep our fingers away from their butt crack. We want people to be comfortable when they're having palpation done. And if I'm going to be palpating somebody below their belt line, or if I'm going to be exposing skin, I always ask first, because we want to make sure that the patient is comfortable with what we're doing prior to us doing it. We want to palpate muscles bilaterally, so preferably at the same time, because it gives us a better idea instead of having to remember side to side. And remember too that somebody might have referred pain. So just because somebody might have pain in one spot where you're palpating, but then the majority of the day their pain is actually somewhere else. That's really common with back pain. As far as special tests for the spine, we want to use levels of pain and motion restriction to dictate what kind of tests we're going to do. So usually we start off with the person's motions that hurt them. We'll have them do forward bending and backward bending, so we'll ask them to reach down and touch their toes, and then lean back and look up at the sky as far as they can without pain. When we do that, I like to have my hands near them so that they don't fall over. We'll do side bending, so tracing the right hand down towards the right knee as far as they can go, tracing the left hand down toward the left knee as far as they can go, and then rotation. So I'll ask them to, with keeping their hips still, they're going to rotate around and look over their right shoulder and then look over their left shoulder. If they have pain or restriction in these motions, it gives us a better idea of what their possible injury could be. We don't do, same thing with the neck. We'll do for forward bending, backward bending, side bending, and rotation. For the cervical spine, we only do special tests if we do not suspect a fracture. So if they've had an axial load or a blow to the top of the head and they're complaining of midline neck pain, we will not have them do any range of motion or any of the other special tests. Tests for lumbar spine, because people are in a lot of pain oftentimes, we usually will do them in a specific order. So usually we have people do tests in standing, then sitting, then supine on their back, then side lying, then prone, just to minimize the amount that they're moving around, because oftentimes, especially for the very acute back injury, people have a lot of pain with movement. We do also want to check the strength and flexibility of the hips, back, and abdominals. That we talk a lot about in our clinic, and we do a lot of patient education on lumbopelvic stability. The muscles in the hips have a lot to do. It gives us a really good base for the strength for the spine to sit on, basically. So the muscles in the hips are actually really relevant to back pain as well. Some special tests for the lumbar spine. We have 3 on this slide. The first is the slump sit test. So what we'll have them do, this is to test for a disc injury. We'll have them first sit with bad posture. So they'll kind of lean forward and curve their back in a C-type position. Then they'll bring their knee up straight. And if that hurts, we stop the test right there. If that causes shooting pain down their leg, we'll stop the test right there. That would be a positive test, is shooting pain down the leg. If they are still okay there, though, we'll have them dorsiflex the foot, so let them bring the foot up. If that's still okay, then we'll have them curve their head forward. And if that elicits pain down the leg, then we'll have them look up. And if the pain goes away, then that's an indication that they're having some pain from nerve tension. Because when we've gotten into that curved C position with the head down and the foot up, the nerves in the legs are actually at their biggest stretch, or the nerves from the lumbar spine down to the leg are at their biggest stretch, and that tends to cause discomfort in people who have disc injuries. So that's one type of injury we're testing for there. Another type would be a lumbar fracture. So this would be for somebody who has just a legitimate lumbar fracture, or maybe even a spondy, which is we're going to talk about later. But basically what we have the person do is lay on their stomach. They'll be in almost like a starting push-up position with their hands under their shoulders, but then they'll keep their hips down, and then they'll rotate their chest up to the sky like a cobra position in yoga. And if they have pain directly over the spine with that, then we might be concerned for spondy in that case, or a fracture. Next, we have a straight leg raise test. So we use this sometimes for hamstring flexibility, but also as the leg comes up, it puts increased pressure on the SI joint, or the sacroiliac joint in the back. Also, if somebody's having a lot of shooting, burning, tingling type pain down the leg, that would be more of an indication of sciatic nerve pain. And if when we raise the leg up, the person's having pain in their back, then that could be an indication of a low back or lumbar spine injury. So with this one, if we bring the leg up and the person just feels tight in the hamstring, that would be a hamstring tightness test. But if they're getting shooting pain down their leg, especially if it goes down to the foot, that would be more of a nerve injury that we're thinking. The first injury we're going to discuss is cervical fracture and dislocation. So it can be somewhat difficult to tell these apart. The main thing to know is that there's a bad injury with the cervical spine and we don't want to move them. So usually what happens is that this type of injury occurs with an axial load with some cervical flexion. So basically the individual is looking down a little bit and they get hit directly on the top of their head. And if they also have a little rotation to their head at the same time, then that's more likely to result in a dislocation. So this particular picture right here is showing a dislocation. So this vertebrae has slipped forward on the other vertebrae and has dislocated. We also can have partial dislocations of the neck as well. So just because their neck isn't in a crazy position, we need to follow their symptoms and make sure we're protecting these people who are having a lot of neck pain. So our signs here would be neck point tenderness. So it's usually, if somebody has a fracture, they're going to be tender over the very middle of their neck. They're not going to be tender kind of under their ear or something like that. They're going to have, if we did let them move, which we don't, they could have restricted motion. They could have muscle spasm in their neck. They'll have pain, general pain as well, but when we touch them, we'll be able to find one spot of pain in the middle of the neck. They could have pain in their chest and extremities. They could have numbness in their trunk or limbs, weakness in the trunk or limbs, and loss of bowel or bladder control. Our nerves coming from our spine dictate all of those things, and so if the nerves are damaged from a fracture or dislocation, then we're going to have some problems. If a dislocation also occurs, then they could have any or all of those symptoms as well, and they'll also have an awkward position of the neck. So they could have considerable pain, numbness, weakness, paralysis, or an awkward position of the neck. If it's a partial dislocation or a subluxation that goes in and goes out and comes back in, then that wouldn't be as noticeable, but the person would still have midline neck pain. treatment here would be, we're going to treat like they're unconscious until a fracture is otherwise ruled out. So we don't let them move. If they are already standing, we may ask them to carefully lay down on their back so that they don't move their neck any more than they have to. Or we'll hold C-spine, so we'll hold their head in whatever position we found them as much as we can. Whenever we ask people questions, also when they have we suspect they have a cervical fracture, we always remind them, if I ask you a question, please answer with words. Don't nod your head or shake your head, because people always do that. But we want to use extreme care. We really don't want these people moving any more than they have to. We're going to call 911, stabilize the head, and we don't let them move. I've seen many people that I've held in C-spine and called 911, and to my knowledge, all of them have been fine except for one, and it was one that I missed because he also had a bad concussion. And he was a wrestler, and in the match right before his, the athlete had run out of blood time, so I was in the middle of cleaning up this other student athlete when this particular kid was picked up from the mat and not returned safely, because it was a JV match and he was a freshman, so it just they're not as controlled as some of the older wrestlers. And he had a concussion. I actually didn't even know that it had happened, because I was treating another person, and somebody said, oh, Billy Bob over there is acting really weird, you might want to go check him. He was sitting in the stands by himself, and I went over to check on him, and I could tell he had a concussion. He was pretty out of it. He wasn't even oriented by 4. His parents were out for the evening. He was actually supposed to go stay with a friend, so I ended up taking him to the hospital myself because I was concerned about his concussion. And I did ask him multiple times if his neck hurt, because I knew that he had been kind of dropped on his head, but he kept saying, no, it doesn't hurt, it doesn't hurt. The biggest mistake I made is I didn't palpate his neck. I didn't touch his neck to see if he had pain, because he kept denying it. So I put him in my car. The hospital that was close to it was an away match, so the hospital that was closer to where we lived was about half an hour away. And about 15 minutes into the drive, he started complaining about neck pain. So I just basically told him, stay still, don't move your head, and I'm going to drive really carefully. So I got him to the hospital, and I said, he's got neck pain. You should probably be careful. Maybe C-spine him. They didn't. They put him in a wheelchair. The hospital staff put him in a wheelchair. They got him out of the car, and I found out the next day that he'd actually subluxed his C1 and C2 vertebrae. So if I had gone over a bad bump, or if he had turned his head really hard, or something along those lines, he could have been paralyzed. So that was really scary. So now I am a lot more cognizant of clearing the person's neck when they're having a bad concussive situation, because he honestly truly didn't know his neck hurt because he was so concussed. So we do want to keep that in mind too, that even athletes with an altered level of consciousness may not know that they're having pain. So a slightly less serious injury that is still fairly painful would be a cervical strain or a sprain. And it can be difficult to tell the difference between these two, actually. Our mechanism here would be a sudden turn of the head, forced flexion, extension, or rotation. So anytime the head is forced into an extreme position. Strains injure the neck muscles, and sprains injure ligaments. Some of the muscles in the neck, though, are very, very small, and they're really close to the spine, so it can be kind of difficult to tell the difference between the two. The person's probably going to have localized pain, but they'll also be point tender over specific areas as well. They could have restricted motion, so even if they have a sprain, they could still have restricted motion because the muscles are spasming to protect that area. So most likely they'll be restricted in flexion, extension, rotation, or lateral flexion. It's hard to say. Depends on where their injury is and what muscles are affected. They won't really want to move their neck. They'll be nervous to move their neck, or their neck just won't want to move. If the person has a sprain, the symptoms will last longer. Our treatment here would be price, and as far as price goes, the protection aspect would be possibly using a cervical collar, like a soft collar maybe. If the person has a sprain, we'll want to rule out fracture. So again, if the person's got a lot of midline pain, then they should probably be getting an x-ray. Follow-up care would involve range of motion, exercises, so gentle stretching, possibly starting in a supine position instead of in a seated position because that can be more comfortable. And isometrics, so basically all of those motions, so front, back, side, side, and rotation. And then progressing into full isotonic strengthening. Mechanical traction can cause some relaxation with the muscles and can cause the person to feel a little better. So this is actually a mechanical traction, a way to do mechanical traction. It's a little harness there for the head, and then what happens is that the straps here at the top of the harness go to a pulley system, and then the individual pulls on this rope to then pull up here and give themselves some relief of pressure in their neck. We can also do this as clinicians with our hands. We call it manual traction, but this is a way that a patient could do this at home, and it can cause some pain reduction. Another type of injury we can come across with the neck is a brachial plexus injury. So remember we talked about the plexus being the plexi, we have more than one, being a group of nerves that comes out of the spine and then meets in one spot, so that's the plexus. The brachial plexus happens to come out kind of to the side of the neck, almost towards the shoulder. And we can have an injury here as a result of stretching or compression. So this is common in contact sports like football and rugby, when the head is either forced this way, or actually could even, so that could cause damage on this side because of the stretching, but actually sometimes it'll even cause damage on this side because of the pinching. So this is a one-sided injury though, so it'll be either one side or the other when the person gets hurt. Some people refer to this as a burner or a stinger. They are pretty uncomfortable. Unfortunately, they're not uncommon in football, which is why they have a name. But this happens when somebody has had a blow with kind of a twist or a forced lateral flexion, not an axial load on top. So that's how we know the difference between this and, say, for instance, suspected cervical fracture. The other thing is that the sensation should be only on one side. So our signs here would be burning, numbness, and tingling, and pain extending from the shoulder to the hand on one side. They could have loss of function for several minutes, but the symptoms rarely persist. So even if we did nothing, the person would probably be fine within 15 minutes or so. Usually we'll try to ice it to calm it down, and then keep checking their grip strength to make sure that's returned and the strength in their arm and shoulder. If somebody is having repetitive burners or stingers though, it can result in neuritis, which is going to last longer. It becomes more of a chronic condition. And the irritation of the nerves can cause them to be activating the muscles less. You can actually start to get muscle atrophy in any of the muscles that are innervated by those nerves. So I had a young freshman football player once who had enough of these that he actually started to get atrophy in some of his mid-back muscles. I believe it was like his mid-traps and his rhomboids and his rotator cuff all were affected by this. And in his case, thankfully it wasn't permanent, but it could have become permanent if he kept getting the stinger, so he ended up not playing football anymore. Treatment here would be they can return to activity once everything's returned to normal as far as their strength and their sensations. If they're having recurrent problems, we want to start a strengthening and stretching program, making sure that the muscles in that area are appropriately at an appropriate length, because if they have a lot of muscle tension over that brachial plexus, then it can cause more irritation as well. And then we also want to strengthen the neck and possibly the shoulder, depending on if we're seeing atrophy or decreased strength in that side. Sometimes people will try to use padding, like what we call a cowboy collar, to limit neck range of motion during impact for football. A cowboy collar is a piece of padding that projects upwards from the shoulder pads, and it's meant to keep the helmet from whipping back or to the side, basically. Unfortunately, when you're wearing shoulder pads, when you go to tackle somebody, they don't stay still. So the cowboy collar will oftentimes shift or rotate backwards, and so it's not as protective as we would like to think it is, unfortunately. As far as low back pain, chronic low back pain actually is a diagnosis in and of itself. Somebody doesn't have to have a structural problem necessarily to have low back pain. Sometimes people just get it. But we could have certain types of people who'd be more likely to have it. So if somebody has a congenital abnormality, an example of that would be having an extra vertebrae. So I've had several student athletes who've had either, most often, an extra lumbar vertebrae. It'll be usually a little tiny skinny guy that's kind of tacked on at the end. Well, I did have another student athlete who had a compression fracture, and she actually had an extra thoracic vertebrae, which was kind of interesting. That was the first time I'd seen that, but it was her lowest one as well. And we can tell they're extra because they're just, well, first of all, it's an extra one, but they also tend to be smaller and look a little different than the others. The person can have mechanical issues with their spine. So, say for instance, poor posture would definitely cause low back pain. Using poor body mechanics. I can't tell you how many patients I've had throw out their back picking up a pencil or a piece of paper because they were just using bad body mechanics. Obesity is also going to contribute to this because somebody who has a big old belly is going to be pulling on their spine when they're standing or walking for longer periods. But also just on top of that, when somebody's got a lot of extra weight on them, it puts a lot of extra stress on the lumbar vertebrae. Part of the job of the lumbar vertebrae is to hold the body weight. We could have somebody who's had a back trauma, like a car accident or a fall, or somebody just might have chronic low back pain. Our signs here would be pain, possible weakness, limping, muscle spasm, and bony defects. People can have neurological signs and symptoms if the injury is disc-related as well, or sometimes with other types of back injuries as well. So that's not as common with chronic low back pain as it is with either a spondy or a disc issue. Treatment here would be to correct alignment and body mechanics. So we would want to teach them how to lift properly, teach them to squat or lunge as they're trying to pick something up off the ground instead of bending forward from the waist. Teach them to hold, if they have to pick up a heavy object, to bring it to their body before they stand up. Teach them to sit in a position where they're not slouched, things like that. We want to do appropriate strengthening and stretching while avoiding unnecessary stress to the back. I will say at our physical therapy clinic, we straight up strengthen the back. We put them on machines where they have weight on their back in bending and extending and rotation, but we do it in a very safe way. We do it in a pain-free range of motion, and we do it at a pain-free weight. So that pain-free aspect of it is really, really important. You could, if you're a personal trainer and you're treating somebody with low back pain, a lot of people will actually respond well to doing an abbreviated motion on the Roman chair. So, active back extension is not the devil when somebody has low back pain. The biggest thing is making sure that somebody's not doing too much motion. And I don't love things like RDLs or good mornings for patients with low back pain because most of the time they don't have the proper mechanics to do it properly. The other thing is that a lot of times it's not pain-free. So I would not preferentially have somebody doing RDLs, running deadlifts, or good mornings with low back pain, but they can strengthen their back in other ways. Stretching would be possibly like rotational stretching or gentle lumbar flexion or extension, depending on what the person prefers, and also oftentimes hip stretching like hip flexors, piriformis, and hamstrings. Next, we'll discuss lumbar fractures and dislocations. Thankfully, these aren't super common, but they're important to be aware of. Most commonly, we'll see a compression fracture with the lumbar spine. This can happen if somebody has a really big trunk hyperflexion, so if they're snapped forward or if they're pushed forward, or if the person fell from a height and landed on their bottom. So that could even be falling down the stairs, or one of my student athlete who fractured her bottom thoracic and top lumbar vertebrae. She was thrown from her horse. She was an equestrian athlete, and then she fell on her bottom walking down the stairs the next day as well. So that one of those caused it, probably the throw from the horse. So we can have a compression fracture to the body of the vertebrae, so that's what this picture is showing, or to the spinous process possibly, depending on how the person fell, or the transverse process, which is over here. Fractures of the processes are usually from a direct blow though. So another student athlete that I saw was a skier, and she came off a little jump and landed on her back on a rock, and so she had a spinous process fracture. Dislocations are pretty rare. These are really strong vertebrae held together with really strong ligaments and really strong discs, so dislocations are not real common here. For signs, the compression, to be able to rule out a compression fracture, we'll need x-rays, but if somebody's really point tender over the spine, then that would be a reason to try to get x-rays ordered, or if they have a palpable defect over the spine, we would be concerned that they had a fracture. They could have local swelling and or guarding. Most back injuries do not cause swelling, so if we see swelling, that's a little scary. Treatment here would be x-ray and physician referral. We want to transport this person with extreme caution and care to minimize movement of the segment, so we would spine board this person just to make sure that they're staying safe, so we're going to minimize the movement of their spine as much as possible. In the physical therapy clinic, when we have a patient who's had a fracture, they can do some exercises, but we won't be doing any extremes of motion at all, so no flexion, extension, or rotation until that fracture has shown signs of complete healing. A more common low back injury would be a lower back or lumbar strain. Our mechanism for this would be a sudden extension contraction with overload, so probably holding something heavy, often with rotation. Chronic strain can be associated with poor posture or poor mechanics. Signs would be that pain would be diffuse or local, so it could be the whole back or it could be one spot. They're going to have pain with active extension and passive flexion. So when they go to stretch, it's going to be painful, and when they go to extend and activate their muscles, that could also be painful. Treatment here would be price to decrease spasm, followed by a stretching and strengthening program, which is interesting since we just said that stretching and strengthening kind of hurt. But when people have low back pain from any injury, the worst thing they can do is lay in bed for an extended period of time. If they have a strain though, we want to give that strain a little bit to heal. So maybe a week or two, and then we start gentle graded stretching and strengthening. For somebody who has a lot of spasm from a low back strain, honestly, stretching their back, maybe just bending their knees to 90 degrees, that could be a really big stretch for somebody who's in a lot of spasm. So we don't necessarily go straight into, trying to bend over and touch your toes or something like that. Somebody who has a lower back strain could use an elastic wrap or back brace for support and compression. If the strain is bad enough, complete bed rest could be necessary, but again, one of the worst things you can do overall for somebody who has a back injury is tell them to lay down flat and rest, because especially within a week, they'll start to atrophy. The muscles in their spine that stabilize it will start to atrophy, and it tends to cause more chronic pain if they stop moving. NSAIDs can also be helpful. Unfortunately, a lot of doctors will also throw narcotic pain meds at this, so we try to really encourage people to not use those as much if they can help it. Another type of injury or condition that can happen with people who are having a lower back issue is an inflammation of the sciatic nerve. This is, again, oftentimes goes hand in hand with the type piriformis or piriformis syndrome, but it's an inflammation of the sciatic nerve. So the sciatic nerve runs down the length of the leg, and if people are having sciatic pain, they could have pain anywhere from their buttock all the way down to their foot. When people are having pain all the way down to the foot, then that means it's pretty irritated. Usually the less irritated it is, the higher the pain stays. So If the nerve is really irritated, it'll go all the way down to the foot. If it's less irritated, it will stay more in the buttock. The sciatic nerve is vulnerable to torsion or direct blows that place abnormal amounts of stretching or pressure on the nerve. So this could happen if somebody just fell on their bottom and fell directly on something hard and it bruised the nerve basically as well. Our signs here would be pain that arises abruptly or gradually, and it'll produce sharp shooting pain, tingling, and numbness. And it doesn't have to be all of those things at once. We have some patients who primarily just get tingling and numbness, but which to us as clinicians, it's the same thing. Tingling and numbness is the same thing as sharp shooting pain. So if you ever have somebody you're working with who is complaining of tingling and numbness, definitely that's scary to me. I mean, not like scary. I'm going to scare the patient or the client into thinking that they have a huge issue, but I would stop doing what I'm doing if they're complaining of tingling and numbness and try to fix it, or refer them to their doctor if I can't. The person could be sensitive to palpation over the mid-butt cheek, basically, and they could have pain with a straight leg raise that will cause pain to go shooting down their leg. Treatment here would be to rest if they're having acute pain. So rest would be 2 to 3 weeks. So rest doesn't mean they have to sit on their bottom all the time. It just means that they need to not be aggravating the nerve to the extent that they can. Ice can be really helpful with this. I tend to say ice nerve pain. Don't use heat, because ice will tell the nerve to chill out, and heat can excite the nerves. We do want to treat the cause of inflammation. So if it's from that tight piriformis, we're going to want to stretch that. And the person can take NSAIDs as needed for pain. Some people will take other nerve pain medications. There are a lot of them on the market, but a common one would be something like gabapentin. Our next injury we're going to discuss is a herniated disc. So right here, this picture is showing us a picture of the disc material here, and this little red spot over here where the green arrow is pointing, that's showing us a disc herniation. So there's been some kind of abnormal stress on the disc, and the annulus fibrosus, the tough outer donut part of the jelly donut, has been disrupted, and the jelly is leaking out, and that will put pressure on the nerve that's running nearby, oftentimes. So these herniated discs are caused by abnormal stresses and or degeneration. Disc degeneration is very, very common, really in anybody over 40. So it happens fairly early. The herniated discs are actually fairly common as well. In people, basically in populations over 40, I think it's something like at least 50% of people in the 40 to 50 age group with no pain have some herniated disc at some point in their spine. So they're not always painful. But this is caused by abnormal stresses or degeneration. Most often, a forward bend with a twist is the biggest culprit. Signs here would be centrally located pain that will then also radiate unilaterally in a specific pattern. So the person will have low back pain, and they'll also have buttock or leg pain, usually. Symptoms are usually worse in the morning, especially when they're first getting out of bed. Onset can be sudden or gradual, and pain may increase after the person sits and then tries to resume activity. So these are people who don't like to sit. Our patients in the clinic who have really flared up discs do not like to sit. In fact, sometimes they won't even sit in the waiting room. They'll just pace around and wait till they can come back and see us. Or these are the people that get out of their car and they're like, I'm in so much pain after driving to the clinic, and then they feel better once they start doing their exercises. Forward bending and sitting increases pain, while back extension reduces pain. So what we try to do if somebody is having to sit a lot is we try to put them in the most comfortable position possible. So we try to keep them in a greater lordotic curve, or the lumbar spine more forward towards the belly button. So we might put a pillow behind their back if they have to sit a lot, or a lumbar support in their car, say for instance. And then we'll try to limit their forward bending, basically. Straight leg raise to 30 degrees can be painful. Our treatment here would be rest and ice for pain management. And again, that's relative rest. We don't want them doing a ton of of stuff, but we also don't want them to sit on their bottoms forever because that's not going to take care of the problem. Usually if somebody has a newer disc injury, extension exercises can be very curative. So if we have them start to do extension exercises often throughout the day, maybe even as much as once an hour, where they're even just like putting their hands on their hips and leaning back repetitively a couple of times, that can actually decrease their pain a lot. We also ask them to take basically rest sets from sitting, so we'll ask them to get up once an hour. That can be really helpful. And we also do want to do a lot of core stabilization exercises, so a lot of transverse abdominis contractions for these people, and multifidus strengthening as they can tolerate it. Our next injury, or group of injuries we'll talk about, are spondies. So we have 3 different levels of spondee. Spondee is basically an irritation of a very specific part of the vertebrae, or that can turn into a fracture. So we have a spondylolysis. That's an irritation of the vertebrae with no fracture. So that's basically a level 1. Level 2 would be a spondylolysis, which is a degeneration of the vertebrae due to congenital weakness, and the person can get a stress fracture. These are actually not super uncommon. We see these a decent amount in the clinic, especially with age. We can also see a spondylolisthesis, which means that the person has a true fracture and one of the vertebrae has started to slip on the other one. It would be considered an unstable fracture. So the part that we're looking at is called the pars interarticularis. It's kind of it's primarily only seen kind of from an angle at the side, like a 45-degree angle. But with the spondylolysis, we'll have just either a small fracture or a stress fracture. But with the spondylolisthesis, we'll actually get like a slippage forward here. And these can happen in the lumbar spine or actually in the cervical spine as well. You may also see these, if you were looking at an MRI report, being called an anterolithesis or retrolithesis. That's just referring to the direction of the slippage, but it means the same thing. For signs here, the person's going to have pain and persistent aching, low back stiffness with increased pain after activity. So these are going to be people who are really limited in walking, say for instance, or they're going to be people who have more pain in the afternoon or in the evening versus in the morning. They're going to feel a frequent need to change position, and they'll often feel like their back wants to pop or it will pop. And then they feel like that will reduce their pain. They can have localized tenderness over 1 or 2 vertebrae, so usually we'll have a pretty good idea of where it is because they can show us where it hurts the most. Our treatment here would be bracing and occasionally bed rest for 1 to 3 days if it's a really bad flare. But generally speaking, we're going to focus on exercises that control and stabilize the hypermobile segments. So we can do extensor strengthening exercises, but usually we do that more in a neutral position. We don't want to go into a lot of extension because that's going to hurt them. So we don't go past a neutral spine for these people. Most of the time they're going to feel really good with flexion exercises, so more core and abdominal work for these individuals. And so we'll do progressive trunk strengthening, dynamic core strengthening, and a lot of abdominal work. But they could also do, planks or bird dogs or things like that to help strengthen their spine as well. Having that spondylolisthesis will increase their susceptibility to lumbar strains and sprains, and we may need to limit vigorous activity, at least for a little while. I have had athletes who've had these and been able to perform even at a Division I college level. It depends on what their needs of their sport are. So how we see this usually is if somebody were to have an x-ray, this would be a normal x-ray from a 45-degree angle view. We call it a Scotty dog. So it kind of looks like a little Scotty dog right here. That's our Scotty dog. That's a normal view. The spondylolisthesis or the spondylolysis is going to be a Scotty dog that has a collar. So that's our fracture site right there. And again, honestly, it looks bad on x-ray, it sounds bad, but I've had people who perform at a pretty high level with these. The youngest patient that I've had with this was 10. So it can be congenital as well. People can be born with a susceptibility for this injury. Last but not least, we will be talking about sacroiliac joint sprains. We also call these SI sprains. So the person oftentimes will have pain primarily in the buttock region because the SI joint is right here. So this is the posterior iliac crest, and then the pain will be just below that. These can be a result of twisting with both feet on the ground, stumbling forward and kind of stomping hard on one foot, stepping too far down. Say for instance, if you misjudged the depth of a step and you landed really hard on your foot because it was farther than you thought or closer than you thought. Heavy landing on one leg, say for instance from jumping and then landing just on one leg, or bending forward with both knees locked during lifting. So that would be like if somebody was, especially if somebody was locking their knees when they were doing like a good morning or something. Signs here would be palpable pain and tenderness over the joint, medial to the PSIS or the posterior superior iliac spine, and they'll have some muscle guarding, sometimes in the low back, sometimes in the posterior hip or the glute area. The person could have pelvic asymmetries, so we'll probably oftentimes see if we have them march and we put our fingers on their SI joints, one will move more than the other one, or the pelvis on one side or the other will be rotated forward or backwards, and we have different ways of assessing that. Treatment, ice can reduce pain. It's kind of hard to get to the joint because it's actually covered with with a bony ledge. So ice might kind of get to it. If not, it'll at least help with some of the muscle spasm in the surrounding areas. We can use a brace for an acute sprain, and a lot of people do get relief from SI belts or braces. A lot of times they're just kind of, a belt that's maybe 2 to 3 inches wide, and you just put it around your hips and you snug it down, and it helps to add some stability. Strengthening exercises should be used to help stabilize the hip and low back. So really good exercises for this would be bridging and glute medius strengthening. So things like hip abduction or pushing out with the knees and bridging. Those would be my big ones probably. And that is the end of our spine lecture.